And
So what I'm going to talk about tonight is part of the work that the Quad Cities Behavioral Health Coalition is doing. If you're not familiar with the Quad Cities Behavioral Health Coalition, it's a part of the Quad Cities Health Initiative, and their mission is to advance the behavioral health of the residents in the Quad Cities. They have a steering committee that's comprised of 60 plus different agency personnel and leaders of healthcare agencies in the Quad Cities, other community members in the Quad Cities, and their job is really to set the direction and chair the 4 committees of the Behavioral Health Coalition. The 4 committees are the Innovations Committee, which searches for evidence-based practices and other treatment innovations to implement locally. The Funding or Resources Team or Committee, and what they do is they find ways to fund new and existing services and programs in the Quad Cities. The Promotions Team, which is exactly what it sounds like, how to kind of publicize and increase the awareness not only of the work that's being done, but maybe new things that are starting in the Quad Cities. And then the Outcomes Team and Committee, which their task is to develop community, like a scorecard for services, to be able to reflect back to citizens that monitors sort of the state of behavioral health in the Quad Cities. I serve on the Outcomes Committee and I serve on the Innovations Committee. And one of the things, what I really want to talk about tonight is sort of the results of the Outcomes Committee. Long ago, when this started 2+ years ago, our committee started to try to figure out what would a scorecard for Quad Cities behavioral health look like? What items would be on it? What data would we need to collect? And how would we sort of put that back out to the community to kind of get a feel for what we consider to be very foundational level look at the health of behavioral health services in the Quad Cities. So we have representation in this committee from both sides of the river. We have hospital entities. We have outpatient mental health center entities. We've got sort of concerned third parties who aren't service providers on the committee. And what we ended up landing on was a scorecard that I will show you right now. And it's really got 2 parts. The first one is what we called hospital crisis data. So we really wanted to try to find a way to show the community sort of the traffic, if you want to think about it that way, of how many people and who is going to hospitals in psychiatric crisis. And then also what happens, how are they being seen and are they admitted or are they not admitted? Are they kept in the metro area or are they not kept in the metro area? And so what I've got for you here is 3 ways to kind of look at it, or 2 ways to look at it, sorry. First thing, let me say, Genesis Medical Center and Unity Point Health Robert Young Center are really the 2 main hospitals today reporting numbers here. We have grand plans both here and in the next section of the scorecard to expand this and include more providers. We just don't have it today. But you can see there's a 2021 total and a 2020 total. And we're very clear, we don't really know what to think about 2020. It was the first year of the pandemic. It's difficult to measure anything against that. None of these entities were really measuring data in this way prior to 2020. So nonetheless, we're just comparing what we have for 2021, for example, to 2020. Now, it's fair to note, too, that when we put this together, somehow 4th Q 2021 won't leave this page. So I'm not sure what that's referring to, but there's no numbers on here from 4th quarter. These are annual totals for the last 2 years. So I'll start just by showing you the top line, total crisis presentations. So in 2021, it was 9192. 2020, it was 8951. I'll say a couple things about the total crisis presentations. One is, again, we certainly don't have all the data from all the providers all over the Quad Cities in this number. This is just at a Genesis hospital location or at a Unity Point Health hospital location, people presenting in psychiatric crisis. It should include people who have any sort of suicidal intent, but we don't have more than just the number. So I just really want to caution everybody to not make too many inferences based on just what the numbers you're seeing are. From that total number, 9192 in 2021, for example, 19% of those, this is the next line down, were delivered via a telehealth platform. So both Genesis and Unity Point Health Robert Young Center have the ability to do a crisis evaluation, just like we're doing tonight, via an electronic sort of virtual means. It's a low number comparatively, as you might imagine, but it was higher in 2020, where I think all of us locally and probably nationwide, worldwide, tried to really leverage those telehealth platforms. So 19% in 2021 were telehealth, 34% in 2020 were telehealth. The next line is how many of those were face-to-face, and it's really just the other side of that number. So 81% of the remaining crisis presentations that were not telehealth were face-to-face, and then the same sort of metric for 2020, 66% versus 34%. Now, of the total number, 9192 in 2021, 37% of those were admitted locally here. 2% were transferred out of the Quad Cities metropolitan area, and 61% were not admitted. And again, it's difficult to compare to 2020. If you see 37% were admitted in 2021, only 30% were admitted in 2020. And the reason I say it's hard to compare is in 2020, the hospitals in either during COVID or in preparation for COVID surges often were not accepting admissions or didn't have the beds to accept admissions in the way that they did prior to the pandemic. So that could be the reason that that number is 30%. And again, we kind of have to track some of these numbers over time to really know definitively what is real and what isn't, with the first year being a pandemic year. So let me stop right there and just kind of see if people have questions about the hospital crisis data for 2020 or 2021 for the Quad Cities area.
So that's just the data for the Quad City areas. So you're averaging like 25 presentations a day for every day of the year, essentially.
Yes.
That's pretty significant.
Agreed. I think people underestimate the traffic, just to be very honest with you.
Yeah.
And Paul, maybe you said this at the beginning, but the coalition is designed to work on issues in both Scott and Rock Island County, right? That's their
Correct.
catchment area versus the larger metropolitan area.
Yeah. Now, these numbers, I will tell you, do include Muscatine. Unity Point Muscatine does report in these numbers. So while that might not be included in the metro area, like the way most of us maybe think about it, it's included in the total number of crisis presentation. Lori in the chat asked if I know the average, I'm assuming, crisis presentation in Iowa or Illinois, and I don't. It's kind of funny. I think, to the best of my knowledge, there is not another entity like the Quad Cities Behavioral Health Coalition that's looking at data in this way. We actually tried really hard in the outcomes team to identify something we could kind of model after out there in the world in a larger metropolitan area like Chicago or Los Angeles or whatever. And we don't have that today. So I'm not saying we're the only one in America doing this work. I think something about the way we're doing it in the bi-state area with multiple providers contributing data to the same sort of neutral entity. I think we're different in that way.
Paul, do you have those not admitted? Do you have those broken down, coded in some way, somewhere? Not that, I mean, this isn't clearly the place to share that, but do you have that information elsewhere?
Like where they went, if they weren't
no, under not admitted, like the reason for which they were not admitted.
Yeah, I don't have a reason. So, and you'll see when we move into the next section too, the agencies that are reporting data are literally reporting numbers. Now our outcomes team has talked a lot about what's the next step with this data. And that's one we've identified right out of the gates, is when they're not admitted, why and where do they go? And I think the natural third question is, do they get linked up with some other provider in the community that's not a hospital, psychiatric bed? One of the challenges is this data collection is very manual. So literally all these agencies send their Excel spreadsheet into a central person who puts all this together. And so it's at some point, if it gets bigger, I think the coalition needs to investigate a little bit more what I would call professional way to collect data, because this is all just I don't want to say spare time work, but I mean this is what people do in addition to their other jobs.
Mhm. Thank you.
Yeah, those are natural next questions.
Well,
sure.
and I think it's also good to note that if you look at the trends, the two items, like the more crisis presentations face to face, the higher the higher percentage admitted versus ones that are not, where it's
Yep.
not face to face, like the tele.
Yep, agreed. I think if we get a full year of 2022, it might be a little bit better for us to, I don't know, draw inferences or conclusions, because 2020 really was a wild card out. Just as somebody who works at Unity Point Health, I will tell you it was crisis management, start to finish. And I don't think that was a typical year in any way, shape, or form. I mean, our volumes were low. Many people didn't get admitted for whatever the presentation because beds were full with COVID patients. So whether it's a heart problem or a lung problem or a psychiatric problem, so it's when our group gets together and we look at numbers, we do a lot of head scratching trying to compare to 2020, as you might imagine.
Yeah,
Other
that would be
questions?
interesting. That would be interesting to note too, because if you look at transferred out of QC Metro from like 2020 to 2021, I know Illinois was a lot more hard fast on the COVID side versus Iowa being a little more open to it. That'd be interesting to see how many of those were out, on the Illinois side versus the Iowa side.
Right. That's another, I mean, you bring up a good point. Another challenge is you've got two states essentially reporting data, and each state kind of has their own set of laws and things like that. So that's another issue. So in the chat, Brandon had a great comment about checking our numbers against national and state numbers. And again, you can find numbers out there, but when we looked, what we found is it's usually based on a provider for a whole state, as opposed to many providers in one metro area. So we just really didn't find anything that was quite apples to apples, which is why we don't have any sort of target or anything like that. And then Val asked, is Eagle View going to be included in any of these stats? So kind of in the process of incorporating Eagle View into these stats. So some of this reporting started when they were building and then continued as they opened, so on and so forth. So Ross is actually on the NAMI board, their CEO. So I would assume that, yes, we will get Eagle View numbers in here before too long. Other questions on the hospital crisis data? I can move into the next part of the scorecard here. So the next part of the scorecard is outpatient access to care. It was identified in the community health needs assessment that access to care was a problem locally here. So we've got this broken out in a couple different ways. So first, let me say the reporting organizations are Unity Point Health Robert Young Center, Transitions Mental Health Center, which is in Illinois, Mental Health Center, Vera French, which is Iowa, and Community Healthcare, who has psychiatric services in the outpatient site, outpatient clinics. So we looked at this three different ways. One is average third next available appointment. I'll just kind of stop here for a second. The reason we chose average third next available appointment is instead of, I should say, next available appointment. Next available appointment gives you sort of a false impression of access to care, because if I have a walk-in clinic today, for example, I can tell you my next available appointment is 0 business days. Today you can walk in, but what clients have told us repeatedly, I think, is, yeah, but I have to wait 2 or 3 or 4 or 5 or 6 weeks after that to be seen a second time. So sort of what has emerged as an industry standard behavioral healthcare outpatient world is measuring the average third next available appointment in business days. And so we've got this particular stat broken up into what we call prescriber level and then counseling or therapy level providers. And then we have a split by age. So in 2021 for youth 0 to 17, in 2021, it's 13.5 days for our average third next available appointment. And then in 2020, compared to that, it was 15 days. So it looks a little bit better. And again, you can draw all kinds of inferences as to why that is or why that isn't. Same with adults for prescribers moving the other direction, 31.6 days on average for the third next available appointment versus 19 days in 2020. And I would tell you in the outcomes team, one of the things we've identified is in 2020, we leveraged virtual appointment platforms to such a degree that it was wildly easier to get in and keep people in and keep them moving through our system. And so we think that's at least some of the reason the number moved in 2021, because we kind of moved away from some of those virtual methods and back to traditional face-to-face in-clinic appointments.
Well, hey, Paul, so
yeah.
is that the difference with not being able to be seen for so many days after initial visit is because are they specializing or individualizing each person as like, so you do your intro, right, when you do the walk-in, and then they're kind of like maybe trying to clinically diagnose that person or what at that time? Or is it like, because what's stopping them from just doing another walk-in?
Sure. So I think you bring up a great point. And I think that's at least some of it. When the providers get together in the outcomes team and talk about why these numbers move the way they move, some of it is sure. When you come in for your first appointment and it's an assessment and it turns out maybe there's not an emergent need to be seen every week, for example.
Right.
Of course, those appointments will be pushed further out. But I think the challenge is, first of all, as you can tell by the crisis traffic, the need or the demand for people kind of entering and staying in is such that all of the providers really struggle to have what they consider good access. And then it's a different thing if you're somebody who's seeking services. If I'm seeking services today, you tell me that I have to wait 31 days, I may think that's absolutely terrible.
Right.
Or 19 days, or 15 days or 13 days. That may seem like an eternity. So there's all of this sort of perception that is true, and both sides have a perception. And I don't really know of any benchmark that is the best, because at the end of the day, if somebody comes in today and they need help today, we have to do what we can to see them today.
Right.
So again, we're just trying to establish our own benchmark over several measures, over time, I guess you'd say, with several measures. So I will just say out loud, I don't think any of these numbers are good or bad. I think they just are what they are. And as we come out of the pandemic, I think we can really take a harder look at tightening up and maybe adding additional metrics and additional data points to, ask these other questions that we're all asking. These are great questions.
Right. I mean, and there could be outliers, obviously, that throw these numbers way off. I mean, it could be the fact that, some of these people are getting to see him, maybe weekly, but then there's a couple that are out there that haven't talked to you in 4 months and now throw the numbers way off. Right.
Yep.
So,
yeah, exactly. And I will say too, we'll get to the staffing levels in a minute, but if you have any sort of staffing turnover or any change in your staffing levels, all of your access changes by default. So
gotcha.
if you had 100 therapists and you were seeing people every 2 weeks, average third next available, if you lose 15 therapists, everybody's access is going to be squirrely after that. So there's multiple things that influence the numbers, which is why I really encourage people to not infer anything other than just see the numbers and kind of appreciate them for what they are.
Gotcha.
So the counseling and therapy for youth in 2020 was 4 days, third next available. 2021 was 7.3, and for the adult clients in service seeking service, it looked like 2 days in 2020 versus 3.3 days in 2021. So just a little difference comparatively. The middle section is all service volume. So this is just events, if you want to think about it this way. I've heard them described as touches, encounters, that sort of thing. And again, split up the same way. MDs, DOs, APRN, or prescriber level resources. In 2020, 6,306 people seen for a first visit by a prescriber. In 2021, 4,586. And then in 2020 for follow-up visits, 53,313 by the prescriber level, and 2021, 44,633. So you heard me earlier talk about how the need is so great. And it is, it's absolutely staggering to see some of these numbers. I think we were all shocked when we got the numbers put together. Counselors, therapists in 2020 for that first assessment session, 14,407. In 2021, 14,762. So pretty similar, all things considered. And then sessions, a little jump up in sessions, 52,704 in 2020 versus 53,392 in 2021. The third piece we measure in the outpatient access to care is the staffing levels. And this is really just a count. And it is a snapshot, you know, so there's variation that happens between times that we report these numbers, but just a snapshot of how many full-time equivalent staff in each of these sort of categories do agencies have. And so for that same MD, DO, APRN, or prescriber level staff, in 2020, there were 28.36 FTEs of prescribers in the Quad Cities area. In 2021, there were 25.1. So somehow we lost, you know, 3+ FTEs in the course of a year. Counselors or therapists in 2020 locally, 92.17 FTEs, and in 2021, 83.94. So again, lost a number of counselors or therapists, at least to the agencies reporting. It doesn't mean that other agencies who aren't reporting didn't have more or something like that, or hire more, but certainly just movement in the wrong direction in terms of FTEs for these agencies. So let me stop there and see if there are questions about the outpatient access to care data that I'm showing you right now. We report on this quarterly through the Quad City Behavioral Health Coalition, and then we try to do at the end of a year, we try to do a look back on the year and compare to the prior year.
No, the only thing I'm going to say is I think that unfortunately, I think the trend you're going to see even lower amount of individuals per the FTE in 2022.
Yeah, there are some staffing problems this year that are pretty bad for all of the providers that are reporting, and I'm sure other ones as well. A lot of vacancies that just been unable to fill. So
and that's all industry wide, no matter what. I mean, that we're just seeing that everywhere. So
yeah, definitely. So it'll be interesting to see how all of that impacts these other numbers too. You know, certainly we can take a guess how they'll impact them, but
sure.
Yeah. Other questions about any of this data? These questions have been great. I usually, when I talk about this in front of groups, it's absolute silence, and I never know how to interpret that. So this has been a great discussion.
Actually,
and
I have a question.
Please.
Sometimes I hear from peers, and they would call and be upset because they had missed a prior appointment, being in crisis challenge, and then they say they had to wait 3 to 6 months before they're allowed to be seen again. And I'm wondering if that is true, number one, and if so, is that tracked as well? How many missed appointments where people are affected from that?
So I can really only speak for either A, what we've talked about in the outcomes team, and then B, sort of Robert Young Center, Unity Point Robert Young Center, because that's where I work. So from the outcomes team perspective, missed appointments is something that we would like to report going forward. We don't have it today. We think it's another piece of this outpatient access to care story.
Yes.
You know, one of the things that I think you miss out when you only report average third next available appointment, if you don't also report how many no-shows people are having, you know, you really don't understand how much schedule time is getting blocked up by people who haven't shown. And so I think we think it's part of the story. And again, not to blame anybody or anything like that, but it's just, unfortunately, it is something we have to deal with in the outpatient land. It's all, you know, these no-shows. And so everybody's trying to come up with unique ways to combat it. And I don't know that there's a good answer. Walk-in clinics have helped, but they kind of solve one problem and create another, or others, I should say, not just one problem. And then as far as policies on closing people who don't show, I mean, I'm sure every provider sort of got their version of it. But the Robert Young said we don't close people unless they show consistently and consecutively. And so it's not without us trying to engage the client in other means too. So if you're missing an appointment today, you're going to get a call and say, can we reschedule? And if you miss again, we're going to get another call, and we may send somebody to knock on a door, or, you know, leave an appointment slip in the mailbox or something like that. So, I mean, there's various ways we try to reach out and engage people so that we don't have to close them. And so I guess I hear those stories too, I guess is what I would tell you. I hear them about my agency. I hear them about other agencies. And I never know how much is 100% accurate and how much is, again, sort of perception, or just the communication didn't go the way it needed to go, not to excuse any provider or anything like that. I mean, I don't know any providers, and I don't sit in any meetings with providers where they find ways to close people, because that's their business.
I see. Thank you.
Yep, of course. Other questions on the outpatient metrics here? Okay, it sounds like no. I appreciate the great discussion. I really do. And Angela, I can email this document to you so that we can put it wherever we need to put it, so that people can have access to it after this meeting. Okay.
Yes, thank you.
Yeah, of course. At this point, I want to go ahead and pivot. I'm going to stop sharing my screen, and I want to introduce Cecilia Bailey, who's the Executive Director of the Quad Cities Open Network. And welcome, Cecilia. She's going to be discussing the work being done as part of the Quad Cities Behavioral Health Coalition on something called the Zero Suicide Initiative locally here. So take it away, Cecilia.
Thanks, Paul. I'm going to preface this with I'm at home because it's 6:35 and I'm a mom of 4 children. So after I do my introduction, I'm going to go ahead and turn off my screen just to spare you the really cute, she's really cute 4-year-old that could potentially jump in at any time. But she also doesn't like to stay clothed. So I'm going to go ahead and turn off my screen for that purpose, and then I'll continue with my presentation. Ooh, and it looks like, Angela, can you make it available for me to share screen?
We need to make you co-host.
Paul, you might have to do it.
Yep, I just did that, Cecilia.
Okay.
Try it now.
Okay, can we see that?
Yep.
Yep.
So I'm going to, in all the times that I do these presentations with Zoom, sometimes presentation mode works fantastically, and sometimes it's awful. So I'm just going to stay out of presentation mode, if that's okay with everyone, and just kind of walk through things. So yes, I am Cecilia Bailey, and I'm the Executive Director of the Quad Cities Open Network. I sit on the steering committee of the Quad Cities Behavioral Health Coalition, and I chair the funding and resources team. In that role, Quad Cities Open Network also serves as the fiscal agent for the Zero Suicide Initiative. So programs, operations sit with QCon, Quad Cities Open Network, and the vision strategic work sits with the Behavioral Health Coalition. And so then it's my job then to act as liaison and make sure that the vision meets the program work, and then that the evaluation is done at the end. So let's talk a little bit about why the Zero Suicide Initiative is even a thing. So Paul has given a nice overview of the Quad Cities Behavioral Health Coalition. So I'll extend it just a little bit to say that, as he said, it came out of some results from some community assessments done through the Quad Cities Health Initiative. And so what highlighted over and over again, of course, was a need for behavioral health interventions or some sort of collaboration to happen among provider agencies or health and human service agencies as a whole to address behavioral health needs in the Quad Cities area. And so as that coalition began its work, the innovation team went to work on a community initiative that they thought the community could see through and would be beneficial to the Quad Cities area. So with that, zero suicide was highlighted. And here's why. The Quad Cities zero suicide, or the Quad Cities suicide rate in 2019 was above the national average, 16.8 persons per 100,000 locally, compared to the 14.5 per 1,000 residents nationally. And so that to us as Quad citizens represents a significant mental and public health concern. Those numbers themselves are staggering, but specifically because we rate higher than the national average, or we did at this time, that is why the initiative was decided to move forward. If we break that down into what that looks like in the Quad Cities, 53 Quad citizens take their life every year by suicide, and their families and loved ones, of course, are left to deal with the consequences of that suicide. And then in 2019, another 1,300 attempt suicide each year. So the thought was that creating an initiative, when we know that there's many zero suicide or other suicide prevention coalitions and groups and grief groups, and all of those things exist. But the thought is to bring awareness and build and collaborate and put into place data and things in one area that we can work collectively to meet goals and to reduce that number. So what is the intervention? So we have opted to use an evidence-based intervention framework from the Zero Suicide Institute. So the Zero Suicide Institute is an organization that works in best practices to traditionally work within agencies, whether those be hospital systems or other behavioral health entities, and some like what we consider tier 2, which I'll talk about a little bit later, organizations on their best practice protocols. So who is trained, what are the policies, procedures, how are they referred, when people interface with individuals in that agency, how are they, how do they get the treatment they need and the referrals they need when they're presented with somebody with suicidal ideation. So this is an initiative that is comprehensive, it's holistic, it's community-wide, and that's what makes us different. So we know that the Zero Suicide Institute does good work. We also know that from a world view, there are other nations that take a community wide approach to zero suicide, but we haven't found anything nationally that does. And specific to the Quad Cities area, again, working across both sides of the river and all of the things that come with that, and looking at an infrastructure that allows for information referral and looking at SDOHs and all of those things, we wanted to figure out a way to get together and make things work. So again, we decided on the Zero Suicide Institute's framework, which is a seven-step framework, and it does work really throughout the whole community to get people to the services they need. So what does that kind of look like? What is the community approach? So the way we look at things from the Behavioral Health Coalition is that we really kind of have three tiered level organizations or individuals that would interface with someone with potential suicidal ideations. And so that first level would be those tier 1 agencies, right, organizations. So they are the ones that have the skills, resources to assess, treat. They would be your hospital systems, your behavioral health provider providers. Some social service agencies would be in this realm. They're actually intaking, assessing, and then treating individuals with suicidal thoughts, actions, and behaviors. Then you have this level tier, this tiered level 2. And so these are going to be the agencies who potentially screen individuals with suicidal thoughts or interface with them quite frequently, but don't have the skill set or the training, and really probably shouldn't to do the treating, but they are essential when we look at in the line of care. They interface with these individuals quite frequently. So these are going to be your law enforcement agencies, your schools, your health departments, other health care providers, and then other social service agencies too. So when you think of potentially, I throw out like an alternatives for the older adult, somebody who would meet with a client directly and be able to see them and recognize that they have issues, and then would be referring out to a tier 1 individual. So they're going to be the social workers, things like that. And then we have what we consider tier 3 agencies or organizations are really at a community level. So these are going to be your non-direct service providers or your overall community members or organizations or entities such as churches, YMCAs, barbershops, beauty salons, high touch people. We interface with people every single day, and we have the ability to recognize things, and we have the ability to practice empathetic listening and to really guide people into assistance. I think the thing that I always appreciate that Rich Whitaker of your French always says is, what we're really looking to do in this initiative is kind of flip things on end and recognize that a clinician treating suicidal ideation is really at a crisis level, right? Like we have so many opportunities as a community to intervene before then. And so we're really looking at a holistic approach to involve the whole entire community on best practices and train them appropriately to be able to interface with someone and get them to the assistance or help that they need. The caveat to this is what we recognize that there are agencies or organizations that have different tiers. We also understand that within a tiered organization, you're going to have tiers too, right? So if you have a hospital, the clinician is going to be trained at potentially a tier 1 level, but then your janitor might need to be trained too. If somebody walks up to the janitor and is having thoughts, how are they going to interact? How are they going to get them to the person that they need? So it's important to remember that this is a very we're targeting in and we're making tiers, but we also understand that it's a very complex idea and a complex process. So what are our goals? So in order to achieve zero suicide, our final goal is to, in a 3-year period, after 3 years' time, develop a model, an infrastructure that will support a 6-month period in time where there are 0 suicides in the Quad Cities area. And that is a tall task. But we believe that we can get there. And then I'll also put this caveat out there, because we will often have people say, there are a lot of contributing factors to suicide, and like, why would you choose 0? And so our answer is, why wouldn't you choose 0? Like, we think that we'll make a difference if we bring that number from 53 to 52. That's important. But as a benchmark, we don't think any death is acceptable. Any death by suicide is acceptable. So 0, of course, is the goal. So how will we do that? So we anticipate having a 1,000-day awareness campaign. So this is what's going to go out to the community that talks about suicide prevention, explaining that we believe that suicide is preventable, really marketing out that there are things that can be done, and then guiding people to training that can be taken. and really bringing awareness around local things that are happening. We know there are many organizations and groups that have this as a target, so we can bring people in to what they are doing as well. We want 100 organizations participating from every sector. And we mean participating, we're talking about these organizations looking at their policies, their procedures, who's trained at their agency, and developing a true infrastructure on reporting out and referring to organizations for people who present with suicidality. So what we mean here is again, an organization signing up and training their staff is just part of what we're saying. We actually want people and organizations to look at how their policies are written and the procedures that are handled. So it's a really change management and a cultural shift within organizations. And when we look at these organizations, we're not just focusing on health and human service agencies, as one would imagine. I mean, they are certainly very important, but we must realize that understand and realize that there are organizations that have EAP programs that might it might be very valuable for instance, somebody in the private sector to sign in or sign on to this initiative and work through their HR practices and their reporting and their EAP programs on procedures and protocol for someone who they interface with someone who they interface with suicidal ideation. And then the third goal is 1,000 high-touch citizens receive online training in suicide prevention. And that would be, again, those barbershop workers, those hairstylists, the churches. I had this conversation today. I was in a funding meeting and I said, we often put titles on people and their jobs. And I would say without much hesitation that sometimes a bartender or a barber is the best social worker you find, right? Like they're the person who maybe is not trained as a social worker and doesn't have the knowledge that one would, but as far as the relationship is and the building a conversation with and having the ability to impact someone's life, often it's that high touch individual. So to date, this is what we've accomplished to date. We had a $550,000 goal over the next 3 years. To date, we're in year 0. Our official year 1 begins July 1st. So we haven't officially begun yet, but we have raised $240,500 towards our $550,000 goal so far. We have completed our strategic plan, have it in motion. We have 2 staff that are our coordinators for the project who are working to finish out year 0 so that we can launch. Our 1,000-day marketing campaign has actually launched. We launched a month early. And so I'll show you some of the work that we were doing in the next slide, but we are very excited to have actually completed that, the launch of that goal a month early. Our tier introductory meetings are complete. So this means we have met with organizations that have signed on tier 1, tier 2, and tier 3 to discuss next steps. Some things we'll be working on, beginning to look at the beta test groups that will, when we look at policies, procedures, practices, get a layout of land of specifically the tier 1 organizations, what trainings they're already using, what policies, procedures they are looking to update in their agencies. we secured 4 interns for this project. We were elated when we found we asked for 1 intern to look at different areas of this project, including evaluation. And we have had 4 that have been interested. So, so that really quadrupled our capacity to do work. And then we have 1,000 online trainings that have in fact been purchased. And I will say again that we promoted our work on June 1st was the first sneak peek that we got out to the community. And as of today, we had 32 people already signed up to be trained in QPR. And for us, we know to meet our goals, we need 30 per month. So again, we are a month ahead in training.
That's awesome. Do you guys, so in regards to like the amount of donations, because obviously you guys got a really good jump start there. Are you noticing that, is that individual donors? Or are you seeing it more like corporations or what from the donation side?
So the donations to date have only been requested from our local funders. So those are our local philanthropic agencies. We wanted to get buy-in from those major funders so that we could then look at regional state funding and then individual donations. I will tell you, that's not our only funding. Eagle View Behavioral Health, we give a special shout out to. They gave us our first seed money to be able to start writing grants before we had dollars. So we appreciate that very much. And then we did get our first, our website launched on the 1st of this month, and we got our first $20 donation today from an individual.
Awesome.
So the work, we're excited about the work, and we believe that it will be successful. When we look at a community system of care, this is just a little snapshot. Because people are wondering, specifically when we look at integration of agencies into some sort of standardized system. Paul referenced this with outcomes team, getting multiple players to play ball and to give us information that we need to make a true impact. And so one of the ways that we're doing this for Zero Suicide is actually Quad Cities Open Network. Our true mission and the core of what we do is we provide an information and referral system that's standardized across the health and human service agencies. So it's a standardized platform where people can make referrals or organizations can make referrals and then actually see that referral was successful or not, so that we can report those out to the community. So it was agreed upon through the strategic plan that the QCon hub should be enacted to make referrals. So when we're looking at the overall infrastructure of this thing, looking into year 2, we'll be looking at the community being able to make referrals as well as tier 1s, tier 2s, tier 3s overall in one standardized system that will in fact capture data that tells us what's happening, what referrals are successful and why they're not successful, how long it takes for someone to respond to referral, things like that. So that data piece will be collected once that infrastructure is built. So again, it's a lot of work, but we think it's worthwhile work, and we think it's achievable based on the collaboration partners that we have already. I should say that we have, Paul referenced, we have 67 now agencies on the Behavioral Health Coalition. Quad Cities Open Network brings 104 health and human service agencies. Some of those are crossovers. And we have 34 letters of support already. So those are 34 organizations who have already begun the process of integrating into a system. So we've made a lot of progress. The Quad Cities Behavioral Health Coalition has made a lot of progress since its inception. And then again, we're just in year 0 and we're ramping up quite well. So So what can you do? How can you help? Well, we want you to share all the work that's being done. If you know of work or initiatives that are being done on suicide prevention, please let us know. We're reaching out to entities that are doing work to see how we can coordinate, collaborate, to share what they're doing so they can share what we're doing. I think that often we know this and we don't like to say it out loud, but often when you look specifically at grant dollars, some of us look at each other as competitors because we're competing for the same money. Well, we can't help people get where they need to go if we don't look at this collaboratively. So it's important to us that we share the work that's being done across the Quad Cities, and we know that it's important to other specifically grassroots organizations that are doing this work as well. So please share. We are requesting individuals to take that Qpr training. So I have this traintosaveqc.com is the link that you can sign up today to take that initial Qpr training, or if you know someone who that'd be valuable to. Again, those are going to be lay community members who just need to know how to talk to somebody who might present with a suicidal ideation. So if we're looking at clinicians and things like that, then that is something that we will deal at an agency level. So organizations agree to participate. So if your organization is interested, or if you know decision makers at your organization and you want them to be interested, please, we're looking again for 100 organizations to sign up and to look at their policies, procedures, and get moving. The last thing we can always use is signing up to be a trainer. So we're looking at this a little differently as well. So traditionally what happens is we have a lot of groups that will bring in an expert, and specifically with QPR. So they fly in the expert, they pay the money for the trainer, and they train 30 or 40 people, and it's fantastic. Well, from our perspective, we're like, why can't we do that? We think we can. So we're looking for 35 trainers in the Quad Cities area. That QCon under Quad Cities Behavioral Health Coalition will keep their information and utilize them as community trainers within their organizations and within the community to get training to who we need trained. And again, because we control the cost, then that over time will not be nearly as expensive. So if you'd like to be a trainer, please contact. I have Annalisa, my Zero Suicide Coordinator's information there. If you want more information, you can do that as well. The last things I'll share before I open up for additional questions, if this will let me, I'm going to unshare this screen and I'm going to pop open here. So this is the site. It again went live June 1st. It talks about a little bit about Quad Cities Behavioral Health Coalition. There is a donate button. People here can donate in many ways. We have the nominal or the setup donation is $20, but you can of course change that. And then here, if we wanted to register for QPR, then it shows you the link. It's very simple. We're not asking for a lot. You will get a t-shirt for doing the training. As we look at other fundraising events, t-shirts will probably be a thing as promotion. So that's one thing. And then I'll just share out. Give me 1 second. Oops, didn't like me. And hopefully my volume will play. The commercial. Can you hear that?
Yes. Well, a little bit.
No.
All right, now I can't hear it.
So I heard some people could hear it, some people couldn't. I encourage you to go ahead and share that link. We're asking, it's a YouTube link, to share across your pages. That's how we're hoping to get out to the community that those 1,000 Qpr trainings are available. And I will point out to you that all the actors in that video are from the QC, and have all been affected by suicide in some way. So it's all very personal to them, as well as me, who happens to be impacted by suicide as well. And with that, I will open it up for questions.
Cecilia, there was a question in chat asking if somebody said they got a request to sign up for a training on the Quad Cities Open Network on Facebook and wanted to know if you're associated with that.
So Quad Cities Open Network is me.
Okay.
So we did share out. So the thing that we will find, that we have found, and we know that we will continue to find, is this being a coordinated effort, you will probably get bombarded and hit from multiple different entities with the same information, which I understand and appreciate can be annoying. But I also understand and appreciate that generally it takes somebody 7 to 10 interactions with something before they'll do it. So
Right.
Sorry, not sorry.
Can relate.
That's a fair assessment, by the way.
At least it's not about my car's warranty, Cecilia.
No, yeah.
Okay, so who's responsible for the cost of the QPR training?
So currently we are taking on the cost. We fundraised specifically for that. For the QPR training to train trainers, we are hoping to have funds specific to that as well. That is rather expensive, but we understand and appreciate that that's why it hasn't happened locally. So we are still trying to work out right now if we will use existing dollars to do that, or if we will fundraise separately. I think my answer is we'll fundraise separately specific to that purpose. But for the overall community trainings, the answer is we've been asked that too, Brandon. So we talked about Rock Island, Scott County, right, as Quad Cities metro area. But as Paul said, what we understand is that many people identify as a Quad citizen who are outside that metro area. So at this time, while our funding is predominantly we're probably being funded to pay for things in Rock Island, Scott County, we're also doing additional fundraisers that don't have those limitations, as well as accepting donations to be able to offset costs for people who want to be trained that aren't in the Quad Cities area. I find it incredibly frustrating that we would tell somebody who lives and works in the Rock Island or Scott County, or has a loved one at any time, that I'm sorry, we can't pay for your training, even though you might very well be impacting somebody in the Quad Cities.
Thank you.
Cecilia, so kudos to you on your fundraising success and being ahead on some of your goals and benchmarking. What do you think contributes to that success so far?
I think that there's always the work that was done ahead, right? Quad Cities Behavioral Health Coalition has been at this work since 2018, so this is not something that's really new. But telling the story and connecting, I shared the stats. But what we find is that so many people are connected. I didn't know when we started this work, and I told my staff, this is what we're going to do, and there was no pushback at all, because out of all of my staff, every single one of them has been impacted by suicide. A friend, their own mental health issues, whatever. So it's something that connects to so many of us, even though it's so understated. So I think that our success so far really speaks to the community's real need and passion for this work.
Other questions for Cecilia? Sounds like no. Cecilia, I really appreciate it. You know, I feel like I'm in like 3 coalition meetings a month, and I've yet to see the slide deck you presented tonight. So thank you for new information. I don't know how I missed that one.
Well, I will say that this is a new presentation. So although some of those slides have been shared out, and like I said, that some of that information you are the first to present, specifically the commercial and the website that just launched, literally just launched the 1st of this month. So
Very cool. It's neat to see it. I was in and around in 2018 when it started, so it's nice to kind of see it go the whole way here. Really done some great work for sure. Last chance for questions for Cecilia, or if anybody thought of a question for the outcomes metrics I was showing you, I'm happy to answer that as well. Okay, it sounds like no, we have completed our agenda in totality, which is nice to have everything done and behind us. So I'm going to go ahead and adjourn the meeting and thank you all for spending time with us tonight. And looks like we're out a little early, so congrats on the free time.
Thank you so much, everyone.
Thanks,
Thank
Cecilia.
you.
Later.
Thank
Thanks,
Thank you,
everyone.
Thanks,
Cecilia.
everyone.
Bye, everybody.
Okay.
Thanks
Bye.
a lot.